Welcome to the second session of the Allergy Symposium. Over to Dr. Masotja, who is an ENT specialist.
Okay, good morning. I'll talk about allergic rhinitis and asthma. As we know, rhinitis is an inflammation of the membranes lining the nose, and therefore with allergic rhinitis, we have an inflammatory response that affects the lining of the nasal mucosa. It is important because it affects social life, school, quality of life, and it contributes to the economic burden. Worldwide, it affects about 10 to 40% of the population, and the incidence is increasing in developing countries. About 38% of the population suffer from allergic rhinitis in South Africa, and currently is the most common atopic disease and one of the leading chronic conditions in children less than 18. It usually presents before the age of 20, and it may be earlier in patients in children that have a family history of atopy. So there are several risk factors, but this frequently increases with age. Children who have a history of food allergy or eczema as related to the allergic match, they are also at risk, and people in higher socioeconomic classes, family history of allergies, firstborns, individuals born during the pollen season, exposure to indoor allergens, and recent studies show that there may be also an association between obesity, nutrition, and atopy. So just like all the allergic diseases, there will be initial contact with the allergen, and with reactivation and mast cell degranulations, then we have mediators of inflammation being released. Then you will have the symptoms of allergic rhinitis. So there are different classifications. This was one that was suggested by Rondel et al., which classifies rhinitis into allergic and non-allergic rhinitis, which is important because we must remember that there is a group of non-allergic causes of rhinitis, which includes irritants, food, gastroesophageal reflux, or it may be drug-induced and others. And allergic rhinitis with this classification can be classified as a seasonal or seasonal, perennial, or intermittent and persistent. And you do have allergic rhinitis with systemic atopy and local allergic rhinitis without systemic atopy. And we do have a class of non-allergic rhinitis with eosinophilia. So these patients will have perennial nasal symptoms with profound eosinophilia in the nasal secretions with no signs of allergies. And it's usually associated with nasal polyps, bronchial hyperreactivity, non-allergic asthma, and sleep apnea. So the most practical classification is the one that was classified by the area, supported by WHO, and is also in line with the GINA classification of asthma. So this classified allergic rhinitis into intermittent and persistent. So it depends on the how often you get symptoms. So if you get symptoms less than 4 days per week or less than 4 consecutive weeks in a year, then you will be having intermittent allergic rhinitis. Whereas persistent symptoms will be more than 4 days per week or more than 4 consecutive weeks. And both of them can be further reclassified into mild to or moderate to severe allergic rhinitis. So the mild ones will have not much impact on the quality of life, whereas the moderate to severe will be having one or more of these sleep disturbance, impaired daily activities, sports, leisure, impairment of school or work, or troublesome symptoms. But we must remember that although we're talking about intermittent and persistent, In certain provinces in South Africa, we have long pollen season. So you may have patients that fall in between the two. So the allergic rhinitis in children is often misdiagnosed as recurrent colds, and we sometimes see patients that are on antibiotics repeatedly because of the misdiagnosis. And when cough is present, especially at night, it may be misdiagnosed as covalent asthma. So the clinicians, it's important for the clinician to ask direct questions and specific questions. And you must be aware of comorbidities when you manage these patients, because most of them have comorbid asthma. They may have otitis media or sinusitis. And sometimes administering therapeutic trials of anti-inflammatory may assist you with the medication. And remember, the quality of life may even be worse in worse than some asthmatics. So the clinical presentation will actually depend on what happens during the inflammatory response. The most common symptoms will be nasal itching, sneezing, rhinorrhea, and postnasal drip. And about 90% of the patients with allergic rhinitis have a blocked nose. They may also have repeated throat clearing, hyposmia, hyponasal speech, epistaxis, or they may have eye symptoms. And 20% of these patients have symptoms of asthma. And clinically, they will present with the allergic salute, which is a sort of an upward sweeping movement of the nose. It's due to nasal irritation. They may use the fingers, palm of the back of the hand. They may have an allergic nasal crease, which is that crease that is formed by the allergic salute. They may have allergic shyness, due to congestion and inflammation around the lower eyelids. They may have the Denny Morgan's lines. These look like just wrinkles, but what is happening is because of the chronic inflammation there and congestion. They may have grimacing, twitching, and picking of the nose. Sometimes they are mouth breathing. They may have dental malocclusion, and patients should be examined for other allergic diseases like eczema and asthma. So when you examine the nose, they'll be having clear nasal secretions. The mucosa will be dematous. It may look pale, bluish, or grayish. The turbinates, especially the inferior turbinate, will be swollen, and some may also have nasal polyps developing already. So they may also have associated allergic conjunctivitis. There are several diagnostic tests, which Dr. Mabelani knows more about them than me, but a skin prick test is one of the most reliable tests. And but remember, children younger than a year old may not display positive reaction, and children with seasonal allergic disease may not have a positive test until 2 seasons of exposure. And what you test for should be guided by the history and the prevalent aeroallergens in the area. And so you look at the geographic distribution when you do this. The total IgE, and I'm mentioning this specifically because many people like just testing total IgE. It's not useful. It's just confirmation of the presence of IgE antibodies. Well, for some of us, it may just be helpful to say to convince the family that this is allergy associated, but we must remember IgE may be raised in certain other diseases, not only in allergies. Immunocap is a rather sensitive and specific blood test, and that should be the test of choice if you want in vitro test. And the ultimate standard for diagnosis will remain a combination of a positive history, presence of specific IgE antibodies, and the demonstration that symptoms are as a result of IgE-mediated inflammation. So the skin prick tests are better when it comes to expense. They're less expensive, they have a greater specificity, and the results are available immediately. whereas the serum immunoassays, there's no risk for the patient. They are not suppressed by antihistamines, because remember, when you do a skin prick test, the patient must be off antihistamines for some time. And they may be preferable to a skin prick test if the patient has a dermatitis or in children. So the South African Allergic Rhinitis Working Group suggests that this algorithm, which I think you can just download, just to assist you with which test to choose. But as I said, you also consider the area where you live. For example, if you are in the KZN area, you must remember that we may have oriental cockroaches there. If you are in the Highveld or Free State, you must remember to include moist pollen, because it's a lot there. And so the management will, the first and most important one will be patient education, because just like asthma, if you don't educate the patients or the parents in case of kids about their conditions, the first thing is they won't manage the patient, they won't manage themselves properly, they won't take their corticosteroids properly. If they know that they've got allergies to certain allergens, they won't avoid them. So patient education is important, and I believe for all allergic diseases. The environmental control is also important for patients that have aeroallergens, and there are several things to do depending on whether the patient reacts to dust mites, cockroaches, molds, pollen, and the like. But the gold standard for treatment of allergic rhinitis, just like in asthma, it's a topical corticosteroids. And these are most potent anti-inflammatory medication for management of allergic asthma. They are first line. So they cause vasoconstriction and reduce edema, suppression of cytokine production, and inhibition of the inflammatory cell influx. But the important thing is the patient must be instructed properly on how to use them. And they work best if taken regularly daily or prophylactically in anticipation of pollen season. And this will be for patients with seasonal or intermittent allergic rhinitis. They are safe for long-term use, and they mainly relieve symptoms of nasal pruritus, rhinorrhea, sneezing, and congestions. And they may have some effect on the ocular symptoms. This is just examples of the inhaled corticosteroids. Systemic steroids, just like in asthma, they are not first line. They are only for severe incapacitating allergic rhinitis, and we use them only for short periods. Long-term use is really not recommended. But what we have seen is that oral steroids and sedating antihistamines are often abused by healthcare professionals in the treatment of allergic rhinitis. Second generation antihistamines and newer generations antihistamines may be useful, but as I said, they are also not first line, and they may also have an anti-inflammatory effect. They act to control the wet symptoms of allergic rhinitis, but they are less effective for nasal congestion. So we may add them as second-line treatment after the patient is has used the innate corticosteroids properly. Decongestants are not first line, and unfortunately, these are usually what we see most patients on. So they produce vasoconstriction and relieve nasal congestion. So if used for a long time, they may cause a rebound congestion or nasal congestion, and they may lead to rhinitis medicamentosa. So, and area guidelines suggest that they should not be used in preschool children. So this we use sometimes if the patient is very congested while we are starting the inhaled corticosteroids, just for a short period. These are some of the decongestants that are abused in our country. Saline irrigations improve symptoms, in reducing symptoms and improving the quality of life. They cause improved mucociliary clearance, physical removal of allergens and inflammatory mediators, and they may have a protective effect on the nasal mucosa. They may also improve the effect of inhaled topical corticosteroids. The leukotriene receptor antagonists, they may be considered in patients with asthma and allergic rhinitis as an add-on only, like Dr. Duval say. They are not first, and on their own, they are less effective than in intranasal corticosteroids. There may be a drug of choice for some tried, as it has been alluded before. And we've got many other drugs, mast cell stabilizers, anticholinergics, and monoclonal antibodies. But once you reach this stage, you must ask yourself whether you treated the patient adequately or not. So allergen immunotherapy is also useful. It should be considered in patients who do not respond to combination of environmental control measures and adequate medication, and those who experience substantial side effects with medication, those that have symptoms for a significant portion of the year that require daily treatment, and prefer long-term modulation of their allergic symptoms, but only works in carefully selected patients. It cannot be used for patients who have polysensitization to several unrelated allergic groups, and there are many other contraindications. As Dr. Duval said, it's highly effective for patients with house dust mites or grass pollen allergies. And South African Allergic Rhinitis Working Group also suggested this algorithm for treatment of allergic rhinitis, which I think if you download it and just keep on reminding yourself how to go about this. I'll talk about two misdiagnoses or differential diagnosis of allergic rhinitis. Most patients are misdiagnosed as sinusitis. We must remember that sinuses are air-filled cavities in the skull in our forehead, in our cheeks, and between the eyes. And they drain into the nasal cavity. But if you have sinusitis, which is an acute sinusitis, will be an infection of the sinuses and nasal mucosa. That's why we call it rhinosinusitis. Then you may present with passy discharge or thick rhinorrhea with inflammation and blocked osteomeatal complexes. The patients may suffer from headaches. They may have a fever, but with a chronic sinusitis, obviously is not acute infection. So, but they will have chronic inflammation, chronic congestion, chronic headaches, and blocked nose. And they may have complications. The complications of sinusitis, like orbital complications. They may have osteomyelitis with puffy tumor or intracranial abscesses. So the second misdiagnosis is adenoid hypertrophy. With, as we know, we've got the palatine tonsils and the pharyngeal tonsils. And in children, they usually hypertrophy to a point that they cause chronic nasal obstruction. They are usually associated with also tonsil hypertrophy. And these patients will not respond to the conventional treatment for allergic rhinitis because it's a physical obstruction. So allergic rhinitis and asthma, I always like talking about them because they go together. They are friends. They frequently coexist. Asthma occurs in about 15 to 35% of patients with allergic rhinitis, and nasal symptoms present in approximately 75% of patients with asthma. And remember, allergic rhinitis may aggravate asthma. So the upper and the lower airways are considered a unified morphological and functional unit. They form a continuum, allowing passage of air into and out of the lungs and sharing many anatomical and histological properties. So they share common structures, and that's why they are so called the united airway. So they are both chronic inflammatory diseases of the upper and the lower airway. So upper airway disease, United Airway Disease, it's an airway hypersensitivity syndrome. Management of rhinitis and asthma must be together for better control of both diseases. As also allergic rhinitis is a risk factor for developing asthma, and we know that over 80% of asthmatics have allergic rhinitis. So the one airway, one disease concept. And patients with perennial allergic rhinitis have greater bronchial reactivity than those with seasonal rhinitis. So the upper airway is the first target of the allergen. And therefore, if the intensity of this reaction is low, the disease may just be in the upper airway, or otherwise it may progress and involve the lower airway. Therefore, the treatment of allergic rhinitis can be beneficial to the lower airways also. So just a 1 minute talk on allergic rhinitis and COVID, since now this is the in thing. So sometimes these are the COVID symptoms, and the allergic rhinitis can present the same, but because most of them will have nasal blockage, rhinorrhea, and sneezing. But we know that allergic rhinitis will also be accompanied with itching, and there may be also conjunctivitis diseases like eczema and asthma, whereas COVID may also have fever, present with fever, malaise, anosmia, dry cough, and diarrhea. For us ENTs, we now having patients who present with a loss of smell, who are now confused because some of them had this even before due to the chronic inflammation of the nose, but now they're scared because they've had that if you lose your smell, you've got COVID-19, and they come running to the rooms. So we need to differentiate, because with anosmia or hyposmia of allergic rhinitis, it will happen over time and it will last for a long time, whereas usually with COVID, it's just an acute loss of smell. And some of the patients with allergic rhinitis sneeze a lot. And because some of them relax and say it's just allergic rhinitis, they are thought to be spreading COVID a lot through the sneezing or the rhinorrhea, because they've got a lot of mucus and some don't dispose their tissues off properly. So we always advise the patients with allergic rhinitis to continue taking their treatment, even if they've got COVID, or even now in the midst of COVID, because some are confused, they are not sure what to do, and to continue taking care of themselves, disposing of their tissues properly, and wearing their mask, avoiding sneezing or coughing next to other people. And thanks very much.